Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. I'd like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and emerging. Well, this week we explore sleep again, and together with breathe, sleep and breathe are foundational pillars. And as I've said, every time I speak to someone on a subject, be it sleep, breathe, nourish, move, think, or any other thing, there's always another aspect to it, a different perspective that is worth exploring. Well, my guest today is worth exploring with. My guest is Dr. Dave McCarty. Dave attended medical school at Duke University and completed his internship and residency in internal medicine in Boston at Massachusetts General Hospital. Dave began his career practicing primary healthcare, but after a handful of years in practice, he followed, in his own words, my own white rabbit into a whole new world called sleep medicine. Now, there really is a magical quality about the way Dave approaches this incredibly challenging and complex field of sleep medicine. And when you meet Dave and visit his website and look at his approach to what is really a very challenging field and look at it, because it's such a feast for the eyes. And that includes not only his website, but his newly released book, Empowered Sleep Apnea. You'll understand exactly what I'm talking about. Dave is unique and he's very special. Apart from being an incredibly passionate practitioner, totally devoted to a patient-centered approach, he's also a terrific cartoonist. Yes, cartoonist. When you visit his website and read his book, you will understand why I say that. In 2015, he joined the Colorado Sleep Institute as its first medical director, and the institute was founded as an innovative clinical model developed to bring a comprehensive philosophy to the practice of sleep medicine, placing clinical care, diagnostics, and treatment options, including CPAP therapy and oral appliance therapy, all under the same roof. I hope you enjoyed this conversation I had with Dr. Dave McCarty. Welcome to the show, Dave.
Well, thank you so much. It's a pleasure to be here.
Dave, ever since I was introduced to you and I had the pleasure of going onto your website, and it's a beautiful website, I have to say. There's a real artistic flair there, and you definitely take your people on a journey. But give us a little bit of background about your own journey.
You know, this all began because I learned so much in my journey as a patient-centered sleep medicine specialist. And let me sort of flesh out what that means to me. As I probably don't have to tell you or any of your listeners, sleep apnea is a Lovecraftian nightmare of a disorder. It is so nuanced and so complicated and so fraught with comorbidities and competing diagnoses that it's very hard to get your hands wrapped around it. And in my journey as a sleep medicine provider, I sort of insisted on something that's rather unusual. I kept 1-hour appointments for every one of my patients every day. I followed my patients from the moment they came in the door. I read their sleep study and I followed them up and I checked their data and I kind of got deep into the weeds with them. And what I learned on this journey is there's a lot of suffering that goes on for reasons that are completely unrelated to the disease. I call it the suffering of ignorance. People just don't understand where they're going and they don't understand why they're there. And this suffering is very real and it makes people make profound decisions that have real repercussions down the road. So I kind of learned along the way, we were talking before the show about how you learn your pattern with your patients based on what they need. And based on what their suffering guides you to. So your patients kind of teach you what they need. And I learned basically the material, the information that they needed to know to get them prepared for this journey, okay? And I'll tell you an interesting story. Early on in my career at Colorado Sleep Institute, I got backlogged in cases. And I thought, I know what I'm supposed to tell them. So I'm going to just write them a letter. I'll write each of these patients a letter because I was getting so backlogged with my study review visits. They were booking out months, like 2 months in advance by this point. And I had to find a way to get my sleep study stacked down and get these people educated. So I thought, I'm a writer, I'm a pretty good writer. So I'll write this stuff down and I'll send everybody their own version of what would later become the Bay of narrative and the Coffee Hut discussion on that,
which we're going to go into,
and we'll get into that. And here's where I learned something kind of powerful. That month when I did that, my follow-up rate dropped to less than 50%, whereas prior to that, when I'd been doing this education in person, it was closer to 95%. So people, even though it was me, and even though I was explaining it, people just couldn't get it. They couldn't get their heads wrapped around it. I think the letter came down like a thud, and I learned something, that information is not the same as education that allows agency. So with that in mind, that fail, I consider that an epic fail, because I didn't do so well on the follow-up. I sort of forgot about that experience. When I finished my clinical career and I wanted to write this book of all these lessons that I learned, I kind of forgot that for a moment. And I started to write a handbook, a textbook. And I must have worked on that sucker for 6 months. And every single time I wrote what I had written, it was like that letter writing campaign. It was going to come down like a thud, and it was going to scare people. And I thought to myself, gosh, it's crazy. The information is the cure. I know what the suffering is. I know what the cure is. The question is, how do I get this information into people in a way that feels good, and in a way that makes them feel like they're wanting to explore it? And I didn't know the answer at the time. This is when I recruited my partner, Dr. Ellen Stothard, who is a sleep neuroscientist and someone I met at Colorado Sleep Institute. She is the director of research there. And she's also just a whip crack smart and really, really fun to talk to. And she loves sleep and she loves patient advocacy. So I thought, if there's one way we're going to figure this out, it's by talking about it. And so I figured that we would start a podcast and we would have conversations about these subjects in real time. And it was during that process of producing this podcast that we realized that above all, the headspace had to be fun, and it had to be it had to get people excited. And then one day we both sort of said, wouldn't it be cool to have a map of this adventure? And that's when everything sort of fell into place. The map, I went home that night and I drew that map that's on the website. And we started to sort of think about it as if it's sort of like a journey that you could do for real. And that's when everything kind of fell into place. And I'm really sort of happy. The book actually went off to the publisher today.
So fantastic. Very cathartic experience, isn't it?
Oh my goodness. Yes. It's a bit like, of course, I don't know anything about this, but it feels painful in some ways. I feel like I've given birth to something, Does that ring a bell?
Well, I've had it said that you don't ever finish a book like that. You just abandon it at some point because you can keep on, that's why I do this podcast, really, because after I wrote my book, that was a full stop and a printing. But of course, as soon as it went out, there was something I wish I'd added to it or I wished I'd asked about. And so this is what this is all about. I get to ask people like you questions. You know more than I do, and you answer them, and I learn. Yeah. It's fantastic. Yeah. But Dave, you said so many things there already. I mean, I love the patient-centered approach. And the question that a lot of people ask is, what's the alternative to a patient-centered approach? And sadly, there are many other alternatives, aren't there?
Yeah, well, first of all, what is patient-centered care anyway? That term gets thrown around as if everybody knows what it is. But to me, patient-centered care means that whatever disorder you're working on, you have to sort of get yourself aligned with the patient and look at the world as much as you can through their eyes, with their value system, and what they think is important, because that makes all the difference with something like a sleep disorder, where the symptoms are so nonspecific and the treatments can be sometimes abusive. So you really have to get arm in arm with the patient. And in the podcast, I call patient-centered care. The best example I can think of is the Vulcan mind meld.
Okay.
Where Mr. Spock gets up and he puts his fingers across the face and he says, "Let our minds be one." And he can actually feel what you're feeling. And as a doctor, I can't do that. But I can stop and I can listen, okay? And it's really the starting with are you satisfied with your sleep? That's the starting point of this whole process, because it grounds in the patient's experience. And that's why I really believe that a patient-centered model for sleep is really the only model that makes sense, because it always self-corrects back to the patient, and that's the only opinion that matters.
Yeah, well, I mean, I got into this area through chronic musculoskeletal pain the treatment of headaches, neck aches, jaw pain. And I had a mentor over 30 years ago, a woman by the name of Dr. Janet Travell, who said to me, she was 92 at the time, and she said to me, if you ask your patients the right questions, then often they'll not only tell you what's wrong with them, but they'll sometimes even tell you how to fix it if you're listening carefully enough.
That's the secret. And that's the crazy secret, is that if you teach your patient sort of how the job is done, they'll do it for you, and they'll do it better than you can because they're thinking about it more than you are.
But this journey that you take people on, I thought we could go on it together. You start with what's called the Bay of Narrative, which leads us to the coffee hut. Please explain.
Well, the Bay of Narrative is kind of like an educational loading zone. Okay, so basically the whole point of this educational campaign is to educate listeners, people, and providers that there are 5 reasons to treat sleep apnea. Okay, those 5 reasons are risk, snoring, sleep, wake, and comorbidities. Okay, now I'm going to go through those. But of all of those, the most difficult one to talk about for patients and providers both is the thumb, is the first one. I won't get it confused with the 5-finger approach. But it's column number 1. The first reason to treat is risk. Right. And talking about risk with sleep apnea is incredibly complicated. So in order to do it properly, the patient's going to need some education. You know, there's lots of terms and there's lots of different types of events that can be scored on a study. And on top of that, there's different definitions for how a given event might be scored. Like a hypopnea has 2 different working definitions right now. And so even the metric that we use to describe sleep apnea, which is the AHI, the Apnea Hypopnea Index, which a lot of people sort of treat like it's a blood pressure reading, like this is the way we measure severity. But it's a lot more complicated than that, okay? And even how the AHI is defined can make a difference for how you interpret risk. So
Dave, let's just remind our listener about what apnea and hypopnea are, just going back to a basic.
Great, very basic. The word apnea means not breathing. So apnea, not breathing. Pnea comes from the same root of the word that produces pneumonia, okay? So apnea means not breathing. So that's any event where there is no air going in and out of you, okay? And that can happen either because the airway is blocked or because the person has stopped trying to breathe for a moment, and that's called a central apnea. So we've already gotten into some complexity, 2 different flavors of sleep apnea that might be in the same person at the same time. Obstructive sleep apnea caused by a blockage of the airway, central sleep apnea caused by a pause. The word hypopnea, so hypopnea means underbreathing. So that's an event where for several seconds, at least 10 seconds, the airflow going in and out of the person is limited, okay? And as a result of that limitation, something happens. Maybe it's an arousal from sleep, maybe it's a drop in oxygen. And that's where the definitions diverge. The American Academy of Sleep Medicine definition captures more nuanced events. And so an arousal from sleep with a 30% airflow reduction is what allows a hypopnea to be scored. But for all of the studies that looked at long-term risk, it was the events that caused a 4% desaturation that were caused hypopneas. So large-scale population-based observational cohort studies like the Sleep Health study and the Wisconsin Sleep Cohort, these are magnificent studies that actually demonstrate a mortality risk with sleep apnea. These studies were done with the 4% criteria. So already we get some complexity with how do I interpret my own score, doc? What does this score mean to me? Boy.
And when you are talking about percentages, you're talking about oxygen saturation in the blood?
Well, for percentage drop, yes, desaturations mean how much does the oxygen drop in the bloodstream? Yeah. And it's usually measured in percentages. Normal, quote unquote, is considered to be above 90%. And it's the degree of the droppage that there's some divergence about where to call it a hypopnea, you know? So right at the very definition of the disorder, we start to get some blurriness as to what these terms mean.
But that oxygen saturation is one worth just pausing on for a moment, because I know sometimes in our practice we might have a pulse oximeter on the finger measuring patients' oxygen saturation. And we know that if it drops below 92%, we stop. We just pause for a moment and just think. So you're talking about an ideal level of oxygen saturation being what you're saying would be, what would be acceptable?
So this is a very, very interesting question when you start to dig. So what's normal, and when does the number start to cause problems? Okay. How low does it need to be in order to start causing problems? And when you actually start trying to answer that question with evidence, it gets really, really tricky. So, I happen to live at a mile high. I live at 5,400 feet above sea level. And there are a lot of people that just through attrition of age, their lungs just don't exchange gases anymore when they're 70 years old. And they may be desatting into the high 80s when they're sleeping with no evidence of obstructive sleep apnea. So the question becomes, is that a health risk? And the answer is, well, I don't know. Is it?
Okay.
Does this person have health problems?
Yep.
Does this person have end organ disease that would be threatened by hypoxia? But if the answer is no, just having those low numbers chronically may actually be adaptive, right? It may actually help adapt to that higher mountain atmosphere. So we actually have some population data that says that the risk of cardiovascular death is lower in mountain dwelling population than it is in people age matched at sea level. And that's just weird, right? Because I've seen these studies come in and we can get low numbers, and you have to ask yourself the question, what does this mean to the patient? So it's a difficult one.
Yeah. So back to the apnea and hypopnea, the AHI Index, because we've kind of redefined that. We've defined that for our listener, but it's a measure, AHI Index.
It's a measure of severity. And it's often held up as you have sleep apnea because your AHI is this. And typically when numbers get above 5 per hour, you start getting labeled with the diagnosis of sleep apnea. But not all AHIs are the same in terms of risk. Depends on the types of events that were scored. So even higher numbers may not contain the same amount of risk in all cases. So this is why the AHI is such a difficult number to decode. So Bay of narrative is where we started with this. In order to get the patient squared away and comfortable with the discussion about all this nuance, we have to go through a little bit of that vocabulary first. So usually in the Bay of narrative discussion, we would have our talk about sleep satisfaction. Are you satisfied with your sleep? Yes or no? That draws it back to the patient. If the answer is no, then the task is to rate it on a scale of 1 to 10. Okay. And 10 out of 10 is that it's perfect. There's no problem at all. I never have any issues. 1 out of 10 is that this is about as bad as you can get. Okay. This allows the patient to have a sense of agency and my vote matters. And I'll tell you from experience, when people are not suffering that bad, they'll usually give themselves a 7 or higher. They'll give themselves a passing grade, like 70% to C, when they start getting lower than that, there's some suffering and they're not happy and there's something bad happening for them. And so the next task at hand is to help them explain why they gave themselves a bad score. And this is where the magic happens, because getting them to put it into words, you might find that they've got tons of complaints about their sleep experience, but really no complaints about their daytime experience. So does that person have insomnia yet? So it helps the provider understand the mindset and what's categorically important to the patient. Okay, so that process is, I call that the Bay of narrative, and that's establishing one's sleep-wake complaints. After one does that, one goes through the vocabulary that's involved with discussing risk. And then magically on the island, this is when the island magically allows you to travel to the 5 reasons to treat monument. Okay. And the reason for the distinction, the monument is meant to be weighty. It's always been there. There have always been 5 reasons to treat. I want people to regard that as an immutable concept because it always brings it back to that discussion. But the problem with modern medical care is the education regarding this subject matter is usually sort of blasted at people on a single visit, and it becomes almost a browbeating ceremony to get people to use the treatment of choice. The way our healthcare system has fragmented, the person usually doing that education is not the person who's read the sleep study. And oftentimes there's a script element to it. So to the patient, it's all well and good. The system is trying to be efficient. It's trying to get people into CPAP machines. But to the patient, that feels like they're being railroaded and they don't feel listened to. So for that reason, I made the discussion about the 5 reasons. It happens in a place where you have all the time in the world, in the book, I actually describe this place as sort of a liminal space, a place where time stands still, where you're just comfortable and you're relaxed. It's the right mindset to talk about how this matters to you, And so that's the reason for the coffee hut.
Yeah. Well, your allocation of an hour for discussion and a follow-up is just, it's quite
unheard of. It was ridiculous.
It's a very unique approach.
Yeah.
It's a very unique approach.
It was a great way for me to learn this disease.
And it's interesting also to ask patients to score their own sleep, quality, because many people just accept, this is me. This is normal for me. I've never slept any different. What do you mean? You wake up feeling refreshed?
Right.
Well, what's that all about? I didn't even know sleep was about that.
Mm-hmm.
People normalize their own sleep.
And they grow blinders to things. For example, you've probably experienced this in your practice. It frequently occurs that people decide they're not going to come talk to the sleep doctor, even though they snore, even though they've got all these problems, because they have to get up 6 times a night to urinate. And they say, how am I ever going to wear a machine? I have to get up 6 times to urinate. And no one has ever told them that symptom is very likely to improve as soon as they get the sleep apnea fixed. It breaks my heart that people aren't aware, and that those dots have not been connected.
Yeah. And that's an interesting example because, the most extreme example is enuresis with kids, bedwetting. But of course, the adult manifestation of that is I get up at night to go to the bathroom. And people just never make that connection between the way they're breathing as perhaps influencing them getting up at night to go to the bathroom. Yeah. And yet there's a very strong connection.
There's a strong connection.
Yeah. And so the second element of the reasons to treat is one that is ubiquitous almost for people over the age of 40 or 50, snoring.
Yeah. Second reason to treat is snoring, but even that's complicated because sometimes people aren't aware of their own snoring. So they say, no, I don't snore. Mm-hmm. If someone were in the room with them, they'd say they would. So, does it matter? And the truth is, snoring does a lot of things that aren't so hot. The trauma of the vibrational energy back there can be enormous. And there are data that link the development of carotid-specific atherogenesis. I'm talking about building up in here in the carotids, where it doesn't build up elsewhere in the body, sort of as a direct proportion to how much a person snores, so the burden of snoring.
Interesting.
So there's a traumatizing of the endothelium in there, and you're on the right track, But then again, lots of people with sleep apnea don't snore. And they can have perfectly legitimate card-carrying, risk-enhancing sleep apnea and not make a noise. And so they're walking around, maybe they've been told by a doctor that they don't have sleep apnea because they don't snore. So snoring can be something that kind of can provide incorrect information sometimes. So we need to think about it, and that's where the discussion comes in. Do you snore? If so, how much? What position are you in? Is it only when you're sick? Are you just waking up with the aftermath of snoring, like sore throats or a foreign body sensation in the back of the throat, congestion in the nose, that kind of thing?
And I think one of the interesting things about snoring, being a snorer and having been one since my 40s, I used to dismiss it as my wife's problem, not mine. This was now over 20 years ago, Dave.
You saw the light.
Yes, I did. And I kind of dismissed it as, oh, come on, it's not that bad, And then I was asked to leave the bedroom. And then suddenly her problem became my problem, and I wasn't going to do that. And that started this journey that I am still on over 20 years later, which was take snoring seriously, see the difference that it potentially makes to not just myself, but my partner, who I care dearly about. And I actually ended up staying in the bedroom, which is the program. We're doing another program on that, but we won't go into that now. But snoring's an interesting one. It's not just a sociological problem, is it? It's not just a social problem.
Well, it is obviously a social problem, and for that reason, sometimes people don't talk about it, and or they're embarrassed, or they curtail their activities. They won't go on camping trips or something like that because they're embarrassed. On the other hand, it might not be that bad, but still it's a sign that something more severe could be going on. So I don't think we can use snoring as a benchmark for whether the disease is present or not. And people sort of need to have their heads wrapped around that too, you know?
So the next risk is sleep.
So the sleep experience in sleep apnea can sometimes be very disrupted, and sometimes it's not disrupted at all. And I think that for people experiencing this, they need to understand that, you know, just because they sleep fine through the night doesn't necessarily mean there's not a problem. But then again, sometimes people who have sleep apnea really experience insomnia at night, or they experience multiple awakenings, or lots of other different things that happen during sleep, including a sense of just restlessness and inability to get and stay asleep. So because the sleep experience can be so highly variable under this one label, getting a person to talk their way through it and understand how it's impacting them so they know what they're kind of watching when they're going on treatment to see what gets better. That's what this is all about.
And then wake. Wake is the next.
So
risk.
Similar to sleep, the wake experience in a person with sleep apnea can be highly variable. A person might say that I feel fine and I don't experience any daytime neurobehavioral impairment symptoms at all, and while other people might be really sort of destroyed by their symptoms. Their lives may be very different, and even if their disease is mild. So it doesn't necessarily, quote unquote, I don't really like the use of labels like that, because the labels can sometimes carry misinformation. For example, a person with, quote, mild sleep apnea, a low AHI number, might be mild in terms of risk. That person may have really profound symptoms from that problem. And so I dare you to tell that person that their problem is mild, okay? So I shy away from using labels, and I prefer to educate people about the 5 reasons to treat so they can pick apart, you know, why should I do this? The wake experience can be very different for people. Obviously, the wake experience can be impacted by lots of things other than sleep apnea. So being able to accurately define it and talk about it so you can set goals of therapy, that all happens at the coffee hut.
And the last one of the 5 risks to treat is comorbidities, which arguably could be the most important of them all, really, isn't it?
Well, you know, and you have to break it down this way, because sometimes it happens that people ended up in my office referred by a third party having no complaints of their own. You know, I went for a colonoscopy and my oxygen saturations dropped, or I developed atrial fibrillation and my cardiologist said I needed a sleep study. How are you sleeping? I sleep fine. You know, I don't have any complaints at all. So the question then becomes, do they have a problem that is likely to be making other health problems worse? Is this a reason to treat? Okay? So are comorbid conditions a reason to treat? And, you know, the list of, you know this better than anybody, I think, because sleep apnea is such a non-specific stressor because it causes stress by virtue of sleep restriction and sleep fragmentation. And it also causes oxidative stress by virtue of the repetitive oxygen desaturations and the straining in the upper airway. So all of these are physiologic stressors writ large over the long term. And these can make lots of other health problems worse. Things like hypertension, diabetic control gets worse, asthma gets worse, the repetitive hypoxic stress can make gout worse, you know, on and on and on and on and on. And so people can collect these other health problems and they're seeing their specialists. And as your listeners are aware, with a specialist derived system, you know, everybody's kind of managing their own little diagnosis, but nobody's really putting it together as to how all these things relate to each other, you know, and the sleep apnea can be a fulcrum point for a lot of these other health problems. And
the stereotypical person who falls into these high risk areas is someone who's overweight, has a thicker neck, but it's not always like that, is it?
Oh, no. No. In fact, it's sort of the dentists that have taught us a little bit more about the emerging phenotype of sleep apnea. So this is something I get into a little bit in the book because I feel like for people to have mastery over something, they have to kind of understand the history of it. So I have a fun time explaining some of these historical details. But we started all this with a phenotype called Pickwickian syndrome. Okay. Now, for the listeners interested in literary history, this is based on Charles Dickens' first novel, okay, The Posthumous Papers of the Pickwick Club. And there was a character in this novel that was named only Fat Joe. And poor Fat Joe was a young man who snored even when he was awake, and he was always falling asleep. And it was kind of just light comedy in the book. Right around the mid 20th century, people started to write things down in the literature referring to Pickwickian syndrome, because that heavy person snoring, falling asleep in the daytime phenotype was associated with medical disease, pulmonary hypertension and heart failure. And so it started to make sense to notice when people had this Pickwickian phenotype. Right around the 1960s is when people started doing sleep studies. And in 1966, a guy called Henry Gastaut did the first polysomnogram on a series of people with Pickwickian syndrome. And that's where we found out that phenotype was associated with a condition called apnea during sleep. And it was mostly obstructive, but some central apnea is happening back then. So now we have a phenotype causing disease. We've got a sleep study that shows these events. And now we have a disease called sleep apnea. So now we flash forward to these studies that I was talking about, and we prove that this disease can cause early death based only on the number known as the AHI. Boom, we've got a new mindset, Now it's a disease that's defined by a number, And what we're finding as we move forward in time, forward in industrialization, we're finding, and this is coming from the dental and the anthropologic literature, so this is all stuff your listeners should be familiar with, but our skulls have changed shape in the last 100 years, because the primary molding force for our upper jaw is that tongue. As one is breastfeeding, that tongue is kind of sculpting out the upper jaw and making this big, giant sort of, I don't know, it's like the Superdome, if you got a tongue that's really mashing it up there like that. When you're dribbling food in with gravity out of a bottle and really not working that tongue up there, the upper jaw ends up shaped like this. And that tends to collapse the nasal airspace like this, like an umbrella. And that leads to a condition that a lot of the dental sleep medicine providers are familiar with, called chronic mouth breathing and nasal disuse syndrome. And the chronic mouth breathing during development leads to an underdeveloped jaw. So now we're in 2022, and we've been feeding our kids with bottles like this for a generation. We've got a whole group of adults with sleep apnea based on their AHI that's a completely different phenotype than Pickwickian syndrome. And so we're having to get our minds wrapped around that this isn't all the same thing, and we have to understand that on a granular level to the patient, the words sleep apnea really don't mean anything at all. We have to help them figure out what those words mean. And that's what the patient-centered approach is all about.
Mm. I mean, to put a number on that underdevelopment, in my clinical experience of over 40 years, the number of patients that have enough room for all 32 of their teeth that we've evolved to have, just as we've evolved to have 5 fingers on each hand, 5 toes on each foot, 2 eyes, 2 ears. We've got all these body parts that are a certain number that we've evolved with, and we've evolved with 32 teeth. I would say less than 5% of the population have enough room for all 32 teeth, which means there's a narrower airways out there than perhaps ideally should be.
Does that jive with your experience? When you ask those people with the fully developed, 19th century airways, were those people usually breastfed?
They were. It's interesting because I would also add to that the nutrition, preconception nutrition of both mother and father. I would add to that the nutrition of the mother during pregnancy. Is the food nutrient dense? That's a really key, because this is the work of Weston A. Price, who was a dentist in the 1930s looking for tooth decay and found physical degeneration, of which narrow jaws were part of. And then you come into the breastfeeding, the chewing of food and the nutrient density. But the point being that small jaws, narrow teeth, crowded teeth, smaller craniums, in fact, are ubiquitous.
Reminds me of a band I used to listen to called Devo.
Oh, yes. Yes, they wore. Didn't they wear hats?
Yes. That's going the wrong direction, folks. You got to turn that around. Yeah, fascinating stuff. So
Hmm.
I'm very interested in the concept that sleep apnea as a label doesn't mean anything, that
Hmm.
we as providers, it's incumbent on us to help people decode that, what it means to them, because it can be very damaging. Psychologically, you get labeled with this diagnosis, and suddenly you're afraid, and people are telling you got to use this machine or it's going to give you a stroke. Well, that I would argue is unethical if risk kind of on that person's scale is low. I don't think you should browbeat people into using a device that, it isn't really indicated if their disease isn't that bad. So I think at some point the only way we can stitch together this fragmented system is to teach people the information so that they can advocate for themselves and their own narrative, because they're the only common part in all of this adventure, for them.
Well, I'm very often say that your health is just too important to leave to anybody else. You've got to take control of it. No, well, I believe that, and with our help, with guided help. But I think it is important. I mean, I think if you're the sort of individual who doesn't want to know about things, you've got a whole industry waiting to greet you with open arms.
Right.
And it's why the pharmaceutical industry generates $1.2 trillion a year. It's why the medical industry is but taking control of your own health. But coming back to the sleep study, you mentioned sleep study, and I wondered, could you just give us a brief overview, not too technical, of what a sleep study is?
Oh, wow. Yeah. So most sleep studies these days are done at home. Mm-hmm. Okay. That's out of necessity, because doing a study in the lab is really intense and labor intensive and expensive. So most insurance payers really want you to do it at home, and they're really looking for any reason they can to keep you out of the sleep lab. So I'm going to describe a home sleep apnea test. Okay. Most standard home sleep apnea tests these days that conform with the American Academy of Sleep Medicine guidelines are going to have a few different elements on them that are just going to measure the things we care about. Okay, so the first thing is going to be something that goes under the nose. It looks like an oxygen cannula. So think the things that you see people wearing in the ER, but it's not giving you oxygen. It's just measuring air going in and out of you. Okay. There'll usually be a finger probe oximeter measuring oxygen saturations in real time so that you can see patterns when they're going up and down. That's important because it's not static. It goes up and down, and how much and how many times per hour that happens is important. There's usually two stretchy bands, one that goes around the chest and one that goes around the belly. Okay. These are going to measure airway or breathing effort. So when those are moving, that's when you're trying to move. And you can actually get patterns out of the way those are moving too. So when there's a relative upper airway obstruction, and think you're trying to suck air and your airway sucking closed, those abdominal and thoracic bands will get out of sync, and they'll start to seesaw with each other. When there's no obstruction, they move nice and even together. But when there's an obstruction, they start to do this. So there's little patterns that you can see when you start to see relative signs of upper airway obstruction. Finally, there's usually some sort of a position sensor on the device. So the little thing usually hooks into a Walkman-sized device that you'll kind of pin to your shirt, and that has the ability to tell whether you're on your back or on your side or on your stomach. And usually there's some sort of a microphone that'll measure snoring sounds and things like that. Some of these devices are going to have an EKG monitor too. Some of them just get pulse rate from the pulse oximeter. Okay. So overall, it's something on your hand, something under your nose, and things around your chest. You can usually get up and walk around, so it's pretty easy to do. Okay. The weird part about it for people is that they're doing it at home. And so again, if they don't know why they're doing it and they don't know what these things are, if they're feeling disconnected, they might start to feel manhandled by the whole system pushing them through.
Because, the question then becomes, is this measuring a typical night's sleep? I mean, I know that if I wear my ring at night, which I normally don't wear, just something doesn't feel quite right. And that's only a tiny ring. And then I have this little Aura ring here, which I thought is quite interesting because it's the least invasive thing I have, but that's quite a lot of hardware, relatively speaking, to go to bed with.
Yeah. I call that the Heisenberg uncertainty principle of sleep testing.
Okay. Which we just accept. Are we saying that we're just getting a snapshot?
Yeah, it would be so cool, wouldn't it, if we just had like something that you can clip on your head really easy, and it's totally lightweight and makes this diagnosis. Maybe that day is coming, maybe we're going to find out that the AHI isn't all that. We're going to find a better metric, something that combines, EEG waves with pulse ox or something like that. And we'll find a way to quantify this that's better. But right now, the way our system works is you can't get a CPAP machine paid for unless you have an AHI that's high enough. So it's kind of locked into the way the system works. And that doesn't always make sense, because you could have sleep apnea as defined by the Academy, the American Academy of Sleep Medicine, but Medicare doesn't recognize the events that you had scored, so you can't get a machine. And that's very frustrating for a patient, to experience that yourself. Yeah. You kind of get the feeling that everybody's swindling you at some point, and that doesn't feel very good. And it's that signal that I've tuned into from the beginning of my career to kind of, I don't know, I feel like my job as their physician is I'm the guy standing there in this big cave with a torch. And I'm like, look, this is a dangerous pathway here. Let's walk together, because this way is a little scary. So this is what's up ahead. That's my job. So that's what all this education in the Bay of narrative and all that stuff is about.
What a wonderful metaphor. I love that. I like that vision. Now, we've been in the Bay of Narratives and had a cup of coffee at the coffee hut, a chat, and we've outlined the 5 risks. 5 reasons to treat. And now we're coming into the river of decision.
Yes. So once you complete your coffee hut discussion, a little magic happens. You find yourself on the banks of this deep and turbulent river. And there are lots of ways across. Okay. And there's new ways being invented all the time. You'll notice that the river of decision flows out of a lake called the Lake of Innovation. Okay. So the problem with this river is it's very difficult. It's a river that defies physics. So it runs forwards and backwards, and you rarely never know where you're going to end up when you get to the other side. Everybody's hoping for that magic landing at Pleasant Dreams Beach, but oftentimes people end up in the rough. Okay. So the purpose of part 2 is to explain the many different approaches, the many different ways across the river, and to say what we know and what we don't know yet. Okay. And so we talk about standard therapies like CPAP and pros and cons and different things that can go wrong with that, and yada, yada, yada. We talk about standard mandibular advancement oral appliance therapy, that does this and this, but these things can go wrong, and what to expect from that and what it costs. Those are introduced as the standard therapies only because those are what's paid for usually by insurance. Okay. So I call them quote standard. Okay. Not to say that one is perfect or one is better or one is worse. That's just what's paid for. And that's what most people, their providers, are going to talk to them about.
And Dave, just to remind our listener that the CPAP refers to the mask continuous positive. Yeah.
Invented by a countryman of yours.
Yes. I forget. Anyway.
Dr. Alan Sullivan. Yeah. So he invented the CPAP machine with basically stuff he bought at the hardware store and put it together in his garage. And boy, what an invention, way better than a tracheostomy,
Oh, yeah. Wow. And the mandibular one is a mandibular advancement splint, keeping the lower jaw and the tongue slightly forward so it doesn't drop back and block the airways. So they are the 2, as you outlined, the 2 standard ones, but there's more.
There's more. Yeah. So, people will hear about surgeries. And so if you go see a surgeon, you might be offered a surgery. So I wanted people to know kind of when surgeries might be appropriate, when to sort of think about that. And in general, with some exceptions, surgery is now considered more of an adjunctive role in the management of sleep apnea. And there are some exceptions to that, but it's nobody is really saying that you should go get your soft palate and your uvula removed for sleep apnea as a first line measure anymore, although that was happening in the 70s and in the 80s. So the thought has changed quite a bit. We're trying to keep people out of the operating room as much as possible, but still people are going to read these things, and I wanted them to know kind of where the coaching is on this. I also introduced the subject that you're familiar with, known as airway-centered dentistry. To me, I think this is a fascinating field in the development of sleep medicine, and I think it just demonstrates 2 different groups of scientists working with kind of a different philosophy. I think of the medical mindset as doing trials and proving a therapy with, randomized controlled trials, because there are a lot of things out there that can hurt you and a lot of snake oil that we need to sort of prove that it doesn't work. So that mindset is important. But the dentists of our world have always been sort of engineers, and innovators. And it's like the medical world said, here you go. Here's an engineering problem. Here's a room that's too small. And the dentist went, oh, well, how does the airway develop? And what are the tools that we have? And how can we engineer a solution out of this? And voila, a new discipline arises with relatively no data. So we're in a early part of this discipline. I think we're in a time frame when it's tempting for the medical world to sort of start chanting humbug the way they do. And I think it's important that we keep in mind that the patient is in the middle, and any of that sort of, disparaging talk only harms the patient. So one of my goals with empowered sleep apnea is it brings the focus back to the person who this is all about. The patient gives them language to fend for themselves. And anybody, no matter who you are, whether you are a dentist or a physical therapist or a physician or a primary care doctor, we can all have fun with that language and share it with them. Because it is fun to talk about the Bay narrative and the coffee hut and where are you, and are you on treated territory yet, and what kind of complications are you having? It normalizes it and takes this insanely complicated subject and turns it into something we can get our hands around. And quite honestly, I tapped into every ounce of fun that I could find in my psyche, and I have a lot of fun, and I have a comic book of a brain. And this book actually makes you feel good for reading it. So I can't wait to get it out there.
Yeah, I'm looking forward to reading it. I'm looking forward
to get it out there.
Tell me there are other issues we've covered in our podcast many times, not many times, but we've covered myofunctional therapy. We've covered, we've even done some, the buteyko and breathing is a very big focus. I think sleep and breathe are.
Absolutely a data-free zone. In fact, the American Academy of Sleep Medicine just published a paper about all of this, saying, making sense of the noise and saying there's no data. And I want to say there is absolutely no data. Okay. It doesn't mean that learning to breathe through your nose isn't a really good idea. And all of the data suggests we shouldn't be breathing through our mouths. So if there's a system that you can learn to help you breathe through your nose that you can do without going to a doctor, huzzah, right?
Yeah. What's your view of the use of tape on the mouth? I know I read an article in 2015 Journal of Otolaryngology, Head and Neck Surgery, which actually legitimized something that I've been using for quite some time. What's your view of that? I used to recommend that quite a bit, particularly for people who were having problems with oral air venting with their CPAP mask. For the listeners, the part of the problem with using a CPAP machine is you really want people to breathe through their noses because it's healthier overall. But oftentimes people come to the table with a really congested nose. And so right out of the gate, they say to themselves, I'm a mouth breather. And so they go to their medical equipment company and they say, I'm a mouth breather. And they say, okay, let's give you a big giant mask and put it on your face. And as soon as you strap that guy on, it's going to push the mandible backwards and it's going to encourage you to keep your mouth open. That raises the pressure that's needed for the device to work, right? And it encourages you to continue with this unhealthful breathing habit of breathing through your mouth. And the problem with that is part of the issue with the nasal congestion is that the more you don't use your nose, the more your nose gets congested. And that's called nasal disuse syndrome. And a lot of people don't know that. Say that again, Dave. I missed that.
I'm sorry. Nasal disuse syndrome.
Nasal disuse, because I've often thought there's a paradox, isn't there, in that the more they breathe through their mouth, the more likely their nose is to be blocked.
That's right.
So nasal disuse syndrome, I hadn't heard that.
Part of it has to do with the fact that breathing through your nose, pulling air through your nose, helps your nose elaborate good things that help keep it open, like nitric oxide is one of them. Nitric oxide does lots of things in the body, but in the down in the lungs, it helps with gas exchange. So it makes the breathing you're doing more effective. And in the nose, nitric oxide kills microbes. Okay, so this guy is supposed to be, the front blockers for everything. You're breathing through your nose. If you're breathing through your mouth all the time, you're sending everything to your tonsils and challenging those tonsils every day with all these things they shouldn't be dealing with. And so they get big and you continue to breathe through your mouth because your nose is stuffy. So going back to my CPAP patients and the taping, normally if I put somebody on who's got a stuffy nose on a CPAP machine, and I'm gentle enough with the pressures that I'm not forcing air out the mouth, I can get them on a nasal CPAP and nasal disuse syndrome gets better. They stop snoring on their nose. Those tissues aren't rattling around all the time. So everything gets better. But sometimes, no matter what I do, they must have floppy, soft tissues in the back of the throat. The nasal CPAP pushes air out the mouth. So in that setting, a little tape across the mouth can resolve it, and it works well. For what you're talking about, which is teaching people how to breathe through their noses again and become better, I usually gave them coaching to go read Patrick McKeown's book, the Close Your Mouth book, for people that were interested, especially when I saw that they were kind of sitting there with their mouths open, and they're taking these big gulping breaths between sentences. I got the sense that they were really kind of overdoing it with their mouths. The phenotype I'm talking about. Usually these are skinnier people with a smaller face and a skinny nose. Those people would really benefit from doing some Buteyko exercises. I always just sort of felt compelled that I'm a Western trained doctor. I trained at Mass General. So we were all about evidence-based medicine. So I always felt compelled to say, I've got no data to back this up, but breathing through your nose is better for you. If you can learn how to do it this way, I think it's better.
You'll be pleased to know I interviewed Patrick this morning, and his episode will be coming out very close to yours too. So,
well, that's awesome. Way to go, Patrick. I recommended your book to plenty of people.
Well, he's terrific, and I reconnected with him after a couple of years. We talk about, then we're into treated. I mean, the river of decision is something that people work through with all the different alternatives, and there are more than we've even talked about there. But then we're into treated territory, and one of the issues is insomnia. And I wondered how big a problem is insomnia and how do we define it?
Well, so that depends on whom you talk to. Okay. So I once had a patient whose final diagnosis was narcolepsy who came to the clinic complaining of insomnia. So all it means is that the nighttime experience is dysfunctional, disquieting, or unsettling to a patient. And they'll come in with that word on their lips. Okay. When you start looking into people studying insomnia, then there are all these definitions, having difficulty more often than not, for at least 3 months, and it's causing significant difficulties. So the people are trying to be able to create a silo so this can be studied. And in my experience, the word insomnia is so nebulous that it can become almost meaningless, which gets us back to the Bay of narrative and sleep-wake complaints. Okay. So that's why that's foundational. But to your point, having continued difficulties with sleep or wake on treatment is the rule. Okay. So I describe this in the book with something I call baseball talk. This is a little fun. It's just kind of a side throw off chapter, but I think people need to know that not everybody's a home run. Not everybody puts that PAP machine on and is like, woo, this is the best thing ever. Home runs like that, they're annoying, because they talk about it all the time, and then you can't get their CPAP machine out of their hand, and their doctors love them because it's just easy. Oh yeah, keep using CPAP, great. See ya, but that's in my clinic. Home runs were about 30-35%, which means that, 65-70% of people aren't home runs. So what are they? Well, you got your base hit, somebody who, gets some complaints get better, but not all of them. I have something called the slow ball. Okay. This is somebody who comes in with all kinds of sleep-wake complaints. You put them on treatment and it doesn't get better until they've been using their treatment for a while. As their autonomic nervous system settles down, then they start sleeping better at night a year into treatment. Okay. And the problem is you never know who's going to be your delayed responder. So this is why coaching is, because think about it. If a person comes in, I can't sleep and I'm tired, you send them home with a CPAP machine. And after a week, they're like, I can't sleep and I'm tired and I've got a mask on my face. Well, that person's not going to keep using that machine unless they've got somebody there to coach them. And that's what these complications and competing diagnoses are about. So basically, in my experience, I came up with a few, and they are Willis-Ekbom disease, which is restless leg syndrome. That often overlaps with sleep apnea because the periodic disturbances of sleep that come from the restless legs component of this, the moving of the legs at night, that can be a trigger for central apneas and central apnea physiology. And so this can be wrapped up like a birthday present inside the diagnosis of sleep apnea. And if you don't fix it, the person getting the sleep apnea treated doesn't get any better. So how do we deal with that? So I talk a little bit about that. I talk a lot about issues that are going to help people understand concepts known as cognitive behavioral therapy for insomnia. Okay, this is all the rage. People are inventing AI apps right and left to teach you CBTI. I think that's great. Okay, for the listeners, cognitive behavioral therapy for insomnia. This is understanding this disorder so that you can choose behaviors and thought processes that won't be maladaptive, that will help you get out of this morass. I found in my clinic anyway, that if you tell people to do CPTI and you don't tell them why, you don't explain it to them, they don't do it because it's hard. And so I like to teach them the science, because the science is cool anyway. Like, understanding how sleep and wake work is really awesome. I mean, seriously.
Spoken like a true sleep physician, David.
I mean, right? Once you sort of understand how it all works, it's just like,
it's true.
Blown.
It's true.
And I found that if I could teach people that, I could see the light bulbs come on in their eyes. Then they're ready for CBTI, and then they do it, and then they'd be successful. So we go through some of the skills of CBTI. I talk a lot about circadian misalignment because in my clinic, delayed circadian sleep phase was everywhere, and this is just a disorder of living in civilization. Our melatonin onsets are just delayed, and so everything about our signaling for sleep is messed up, and it has to do with lights and what we're doing at night and all this activity that we have. So I teach people about that. The thing I do that's different in the book to teach about all these things, because of course in clinic, I only got into it when people had the problem. And then I would sort of look them in the face and we'd have a moment and we'd walk through it. In the book, I had to present these things as if they're different adventures. So I tell stories and I give little vignettes of people, and they're all made up, of course. They're fictional stories, so I'm not giving anybody's personal information away. But they help to illustrate some of the nuance and the humanity associated with this and why these decisions are so important.
And I mean, when we talk about circadian rhythm, boy, that's opening up a whole huge view of the modern world, because every one of our devices, every computer, every TV, every phone, every laptop, every reader has the potential to disrupt our circadian rhythm.
Yeah, and all the non-photic things that are going to mess with our rhythm. So getting anxious and reading and taking in world news and getting yourself all hyped up, that's all working against us. It's all very complicated, but helping people reestablish a healthful and productive and adaptive sleep routine, helping them dig their way out of a morass like a delayed sleep phase, can be very difficult. One of the fun things we did for the book is I invented a tool in clinic, much less fun to look at than the one in the book is, but it was a wheel. So it would help to illustrate the circadian rhythm, okay? And because it turns out that depending on where you are exposed to light and melatonin, it can move your circadian rhythm forwards or backwards. And so it makes a big difference, as to when these stimulations are happening. And that especially gets confusing to teach when people are crossing time zones and trying to give a talk in Europe, and you want to help them get prepared and know when to put the dark glasses on and when to take the melatonin. So I created a gizmo. I call it like a biological decoder ring called the Circadian Rhythmo Wheel. And it's something fun. It's like a Cracker Jack toy. You can pull it out of the book and put it together, but you can actually learn something from it. And you can figure out your own circadian rhythm. So people who are interested, you can actually buy one of these separate from the book on the website. I'm selling them just because I think they're nifty and they're really fun. And anybody who crosses time zones, I think it'd be a fun gadget to have. So it's called the Circadian Rhythmo Wheel. And it's just a fun part of the book. It's a fun part of that gee whiz adventure that I was trying to create.
And you mentioned melatonin, and people, melatonin comes as supplementation, and people sometimes take it when they travel. How should we or could we be using melatonin, and how cautious should we be about its use?
Well, I'll preface this by saying that melatonin, because it's not regulated by the FDA in the United States anyway, I don't know how it's handled in Australia, but over here it's considered a supplement, which means that you really don't, even if it says 5 milligrams on the bottle. This was published, I can't remember the year now. I think it was close to 10 years ago. Someone did an assay of different leading brands, and it was just all over the map. The variance was as much as 500% was on the label. So with that being said, that you don't really know what you're getting, and so you have to really pay attention to how it affects you before you sort of just make a blanket statement. We don't get any signal that melatonin is addictive. We don't get any signal that it's going to cause physical habituation. So as far as an agent to help you sleep, there are worse things. Okay. It has the ability to move your circadian rhythm around, though. So I think that's important, because if melatonin is experienced by the brain on the second half of the night, close to morning, if that's when the melatonin is being observed by cells, by the receptors in the brain, it's going to actually try to delay your circadian sleep phase. Okay. So if you're taking melatonin at bedtime and you're taking an extended release formulation at bedtime, maybe you go to bed and you can't get to sleep and it's 1 a.m, you're like, man, I've got a delayed sleep phase, so I'm going to take my melatonin at bedtime. Most of that is going to be experienced on the second half of the night, and it may be contributing to the problem. Okay. So I think we need to be careful when we kind of choose the formulation. Is it an immediate release or an extended release? Is there any evidence that we were dealing with a circadian misalignment rather than something else? And, once we've thought about all those things, I think it's an agent that I'm not afraid of for my patients, because I've really never seen it go wrong. Mm-hmm. When it goes wrong to the point that people don't like it, it's that they say, I felt really smoky in the morning and I didn't like it. But I've really never clinically encountered anything worse than that.
And is the idea of an immediate release, if say you were taking an immediate release, would you take that an hour or so or two before bed, or at the time of bed? What would be the timing ideally?
It depends on what you're trying to do. So if you're trying to use melatonin as a chronotropic agent, meaning to try to, let's say you're trying to adjust to a new time zone, and you're trying to use all the technology at your disposal, light and melatonin, because both of these elements can move your circadian rhythm, then you're going to want to pay attention to when you're taking it and try and target it. And that's where the wheel comes in. So you can actually turn the wheel around, figure out where your circadian sleep phase is, and then you can see on the clock where the best effect to either advance or delay your sleep phase would be. So for that kind of targeted use, I would use low dose melatonin. We're talking physiologic doses are less than 0.5 milligrams. That's what your brain does. Mm-hmm. So taking doses of 5 milligrams are super therapeutic. They're super physiologic. So if you're taking it to move your circadian rhythm, you're using a low dose, and you're actually if you're trying to advance your sleep phase, you're taking it 4 hours before you're going to bed, so you're kind of strategizing a little bit. Mm-hmm. If you're using it as a sleeping pill, then you're using doses of, 3 to 5 milligrams, usually that range. And sometimes it's advisable to take an extended release. If you're not worried about the circadian misalignment aspect, that's going to last a little longer and have those soporific effects, those sleep-inducing effects lasting closer to morning.
And then we come into an area you refer to as the 5-fingered approach mountain.
Yes.
Tell us about that.
So there's a story behind this. I mentioned the fact that there was a patient that had narcolepsy as her final diagnosis, who presented with a diagnosis of insomnia. Mm-hmm. So this patient, I described this on the website. I didn't tell all the details, but I gave her the name Daria for the blog, although that wasn't her name. The bottom line is, this patient came in with some sleep-wake complaints, got a diagnosis of sleep apnea, was placed on a treatment, and then got kind of put on the follow-up track. And this patient wasn't educated, didn't talk that much, and just sort of came to clinic. How are you doing on that? Yeah, I'm using it, So it was a limited exchange. So part of the problem here was cultural communication and all the rest, okay? But I came into this patient's care 5 years into her care. And it turns out her sleep apnea wasn't really the problem. She actually had narcolepsy, and that broke my heart that this woman was using this machine, going to all the trouble of coming to visits, being told that she has to do this because she's going to have a stroke if she doesn't, and she really didn't need it. And I felt that there was something ethically wrong there. Mm-hmm. So I wanted to create a system whereby whatever's going on with the patient could always be cross-checked with a checklist. I was fascinated with checklists. That whole checklist manifesto book came out. At the time I was teaching a physical exam class at the medical school. So I was using the Harvey robotic heart sound simulator. The great Dr. Harvey was a legend in medical education, and he came up with the 5-finger approach for the cardiovascular exam. So I was kind of thinking along the lines of, how are we not going to forget again? And that's where I came up with this idea that anytime somebody comes in with a sleep-wake complaint, there's a pretty good likelihood we're going to find more than one thing wrong. So we shouldn't stop with the first label we have a treatment for. That's what happened with poor Daria, is she got labeled and then everybody stopped thinking about her for some reason. So that's called diagnosis-based medicine in my book. I practice patient-centered medicine. So that's where the 5-finger approach came up. And it was really designed around giving us a checklist so we wouldn't make that mistake ever again. And the 5 fingers are: thumb is circadian misalignment. Actually, should go this way, that way, right? Circadian misalignment. The index finger is pharmacologic influences. And I put that on there second because I was training physicians at the time from many different walks of life. Okay. And to get into a sleep medicine fellowship, I was the associate program director and then the program director of the sleep medicine fellowship at LSU Health Sciences Center in Shreveport, Louisiana. And we accepted candidates from multiple walks of life: psychiatrists, family practice, pediatricians. Like, you can come in from many angles. I found that depending on your background, you might be radioactively allergic to reviewing the med list with a patient. The psychiatrist wouldn't even look at the cardiac meds. Okay, to their mind, that was managed by them. So I had to get people into the mindset of thinking about the drug list critically, because as it turns out, there's lots of drugs that do terrible things to sleep and wake, and nobody is even thinking about it. And so they're blaming everything on the sleep apnea when really what they needed to do is switch from a lipid soluble beta blocker to something that's less likely to get into the brain. But if you're not thinking along the lines of, this could be the drug, you're not going to go there. So that's why after circadian misalignment, figuring out where your circadian cycle is, you look at the drugs. The third thing to look at, the middle finger, is medical problems, medical factors, because lots of medical factors can influence sleep and wake for the worse. So the question there is, can we tune up these medical factors any better? Are you having chronic pain that's keeping you awake? Do you have interstitial cystitis that's getting you up every 4 hours to pee? Maybe we can manage that, okay? And if you can't manage the medical problem any better, then not sleeping or feeling fatigued, those are forms of suffering, and those symptoms have potentially relieving treatment courses. So sometimes you need to target the sleep experience. Just because a person can't sleep because they're in pain doesn't mean you can't find a way to maybe give them a little pharmacologic assistance that's safe. So you have to think about medical problems very critically that way. The fourth domain is kind of broad, and it's called psychosocial and psychodynamic. This is where you have to consider the patient's larger mental health situation, their safety at home. I once had a patient who was referred for insomnia because she was being beaten up at home. That's why she couldn't sleep, was because she didn't feel safe, right? That's not a job for Ambien anymore, right? So doing a measured consideration of mental health issues and safety and physical, the physical experience of sleep too. Is it a place where they're comfortable? That kind of thing. I put at the very end, because I was training fellows who were always looking for the obvious, what I call primary sleep diagnoses. So that's when you get to think about, once you've gone through the first 4 fingers, then you can start to blame things on sleep apnea and things that you're kind of used to. Restless leg syndrome, narcolepsy, idiopathic hypersomnia. These are kind of standard bread and butter sleep medicine diagnoses that you get labeled with. Those are common things to be labeled with. So, and I wanted my fellows to think about those things last, okay? And it's because if you skip the first 4, you're likely to get to that first, and then off you go to chart legend land, and that person doesn't get the attention they need, okay?
Wow. How do you diagnose narcolepsy?
Narcolepsy, oh boy, fascinating disease. So for what it is, narcolepsy is...
Just remind us of what it is. So
everybody knows what type 1 diabetes is, right? That's where the pancreas has specific cells in there that make insulin. And something happens and you get an immunologic experience that makes your body destroy those beta islet cells, those cells that make insulin. All of a sudden, no insulin, you're a diabetic. Boy, in the old days, that would kill you if you didn't get insulin replacement therapy. But that's an immunologic model of a disease process. We think narcolepsy is the same way. There is a small set of neurons in the hypothalamus that make a neurotransmitter called hypocretin. And this neurotransmitter's job is to do lots of things, including regulate the neurotransmitters that keep you awake. And it regulates the mechanisms of REM sleep. And REM sleep is one of the most fascinating rabbit holes in all of sleep medicine. REM sleep is where you have dreams, and REM sleep is where your body is paralyzed while you're dreaming to protect you from running around. Well, it turns out when you screw up hypocretin and you make it disappear, it becomes very difficult to maintain states. So being awake and maintaining wakefulness becomes very difficult. People just nod off. They can't deal with mounting sleep pressure, so they just fall asleep out of nowhere. The elements of REM kind of come springing out of the box, out of nowhere. So the paralysis that goes along with REM can sometimes intrude on wake because of a strong emotion, which is weird, right? That sleep paralysis that's supposed to happen only when you're dreaming can happen because you're frightened or because you laugh. And how about that for weird? Explaining to your friends why you fell down the stairs because they told you a joke. You know? So not being able to stay asleep at night because it's a problem of maintaining states. That's why my patient came to the sleep doctor complaining of insomnia when her final diagnosis was narcolepsy. She had a disrupted nocturnal experience. She felt tired a lot during the daytime, was noticing she was falling asleep. The way she interpreted that narrative was, I don't sleep well at night. Isn't it weird? Right?
Wow. And finally, we come into the Pleasant Dreams Beach, which is, I'm assuming, where everyone wants to be.
Boy, yeah, Happy Z's sheep counting ranch and Pleasant Dreams Beach. I mean, this is where we all want to go. And I put it as a physical location on the island because that's our destination, but not everybody gets there. And I didn't want people who didn't get there right out of the gate. I didn't want them to feel like they were failures or feel like there was something wrong with them or feel like, I don't know, that somehow this wasn't for them or someone was trying to rip them off. I wanted people to understand that even if you're not there, there's a process. And, you know, I'll tell you right now, if you're not at Pleasant Dreams Beach, it's a good time to go to Five Finger Approach Mountain and take a look around because it can usually help you figure out some things that you can do to get you there.
Wow. Dave, this has been fantastic. It's been like, I feel like I've had a fellowship in sleep medicine. But I wanted to ask you just finally, taking a step back from your role as a physician, because we are all individuals on a health journey ourselves in this modern world. What do you think the biggest challenge is for an individual on that journey?
I can't speak for anybody but myself. The biggest challenge for me in navigating this journey was trying to find a way to help people through the system that was fragmented. So that was very challenging for me. And as a result, you know, it's difficult to deal with some of the emotions that come along with that. When I'm spending a lot of time with my patients, I'm seeing proportionally fewer people and I'm making less money. And yet, you know, these people are coming to me with problems diagnosed elsewhere that weren't handled. So that's no one's fault, is what I finally come to. But I had to work through a lot of kind of feelings of anger and resentment about how the system treats people to come to this place where I realized that this happened kind of organically. No one kind of went to the table and said, I'm going to create a system that mistreats people and makes them feel railroaded. But nevertheless, it's there. And that suffering is very real. So I'll tell you, the challenge that I had in my clinical practice was dealing with that suffering on a daily basis and feeling powerless to do anything about it. So this explains why I made the transition that I did. I felt like all these lessons were vital. I could see with my own eyes that when people knew this information and internalized it and had agency, their lives were different. Their management of the disease was different because they were in the game and they felt comfortable with it. This book captures the essence of what it was like to be my patient, but I don't have to be in the room anymore. And it overcomes the problem of that information density with the headspace that we talked about at the very beginning of the discussion.
Well, Dave, thank you so much for joining us today and sharing your wisdom and knowledge with us. And I'm really looking forward to the book, which I'm sure is coming out soon. We'll have links to your website and people can certainly will find it there, I'm sure. So thank you so much for joining us today.
It has been my pleasure. Thank you so much.
Well, from the moment I was first introduced to Dave and I visited his website, and actually he visited mine, we realized there was a great connection there, and it wasn't a disappointment when I met him. I just love his passion. I love his patient-centered approach. I love the fact that he sets aside time to talk to his patients. And as I've said many times, if you listen to your patients, they'll often not only tell you what's wrong with them, but sometimes they'll tell you how to fix it. Sleep medicine's a little bit more complicated than that. But Dave's approach of literally taking you on a journey, and that journey which we covered in the book, in the podcast, and which he covers in his book, Empowered Sleep Apnea, it is a truly unique book. And I would strongly recommend that you visit his site to get a clue as to what he is about, and check out the book, which has just recently been reviewed. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well.
This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.